Hey guys, welcome back. Now we're moving on to the pharmacology section of the chapter, which is a relatively lighter section. However, the drugs here are very boards relevant, so you should spend some time getting to know them. Before we can understand how the drugs work, we'll need to take a look at the arachidonic acid pathway and understand the normal physiology. Though it may take a little effort, memorizing this pathway should prove fairly high yield, as it tends to be one of the more often tested pharmacological pathways, since aspirin, NSAIDs, and acetaminophen all affect it in some way and are all very common drugs. Let's go through it together. I'd recommend copying it down as we go. Let's start at the beginning. Where does the whole process start? Well, the plasma membrane of the cell of many different cells in the body. A single membrane lipid is taken by phospholipase A2 and is converted into arachidonic acid. With this arachidonic acid, there are two directions it can go, either down the lipoxygenase pathway or the cyclooxygenase pathway. The lipoxygenase pathway is simple. Arachidonic acid is ultimately converted into leukotrienes, including LTB, C, and D. Do you recall what LTB4 does from pathology? Very good. Neutrophil chemotaxis. LTC and LTD are potent bronchoconstrictors. Now, while you won't see these again until the respiratory lectures, the drugs xyleutin, zarfalucast, and montelukast all block this lipoxygenase pathway, as it tends to be an effective treatment option to prevent bronchoconstriction in patients with asthma, especially if the asthma happens to be aspirin-induced. To help remember these drugs, note that they all contain Lu in their names. The second pathway that arachidonic acid can take is the cyclooxygenase pathway, or the COX-1 and COX-2 pathway, which converts arachidonic acid into three molecules. The first two are in some sense mirrors of each other. Prostacyclin, or PGI2, decreases platelet aggregation and also vasodilates, while thromboxane increases platelet aggregation and vasoconstricts. One way to remember that thromboxane increases platelet aggregation is in the name. Thrombo is also the root for thrombus, or clot. Now, how do these two molecules function in the body together? Well, they balance each other out to ensure that vascular tone is being regulated appropriately, as is the appropriate activity of the hemostatic pathways. The third product is prostaglandins, like PGE2. These have a wide variety of effects, including decreased vascular tone, increased pain sensation, and increased uterine tone. Can you guess which one of these three molecules is responsible for menstrual cramps? Very good, prostaglandins. They increase uterine tone and are responsible for cramping when the uterus sloughs. Many drugs affect the COX pathways, namely NSAIDs, acetaminophen, and aspirin, which are all nonspecific and block both COX-1 and COX-2. There are specific COX-2 inhibitors that allow the COX-1 pathway to remain intact, which we'll talk about in a few minutes. Corticosteroids also function to block both arms of this pathway. Now, what do they work on? Very good, phospholipase A2 activity, and also the protein synthesis that creates the enzymes COX-1 and COX-2. By doing so, steroids can also be potent anti-inflammatory drugs. Flash quiz. Where does the arachidonic acid pathway start? In the cell membrane with a single phospholipid that is processed by phospholipase A2. Another commonly used drug for analgesia and antipyresis is acetaminophen. Now, how does acetaminophen work? Well, it reversibly inhibits COX in the CNS, and not peripherally where it's made inactive. Therefore, since it can't get to the sites of inflammation directly to block the enzyme, it has no anti-inflammatory effects, and is not technically an NSAID. However, children with fevers do benefit from this drug to reduce the fever and avoid the risk of Reye's syndrome. Acetaminophen notably is metabolized in the liver. Now, what is this metabolism dependent on? Glutathione, which normally neutralizes the toxic metabolites of acetaminophen. If too much is ingested, glutathione stores are depleted and toxic hepatic necrosis can result, which can be life-threatening. Now, what can you do for patients who took too much acetaminophen? Well, you can give them the antidote, which is N-acetylcysteine, which is responsible for restoring normal levels of glutathione. Now, do you recall from the respiratory chapter another use of N-acetylcysteine? Good. It's also used for patients with cystic fibrosis as a mucolytic therapy. Now, what actually is the toxic acetaminophen metabolite? If you said NAPQI, you're correct. Okay, now based on our earlier discussion, what does aspirin block? Good, cyclooxygenase. However, it's important to recognize that aspirin does so by irreversibly inhibiting it via a covalent acetylation. Now, what is the result of this? Well, this reduces production of inflammatory mediators like thromboxane and prostaglandins. How long do you expect aspirin to affect a patient's bleeding time? Well, it generally lasts up to 7 to 10 days, or in other words, the time it takes for the body to replace those platelets. So, should you do an elective surgery on a 50-something-year-old man who's on daily aspirin? Well, no. Just wait a week until his platelets are back in action. The interesting facts about aspirin actually come from the fact that at different doses it has very different effects. At the lowest doses, it's responsible for decreased platelet aggregation, which is important prophylactically for people at risk of heart attacks. Now, what happens at higher doses? Well, the second dose level is an intermediate dose, anywhere from 300 to 2400 milligrams a day, which helps to prevent fever and pain. The highest doses are actually required to decrease inflammation in the way that we'd need it if there was a concern about a potent inflammatory response. Now, what are the side effects of aspirin? Well, the concerns with using aspirin are not trivial, despite the fact that it's such a commonly used drug. The most common is probably gastric upset, which can predispose to a gastric ulcer formation, which can lead to upper GI bleeding. Also, aspirin use has a complex relationship with the kidney during excretion, and its use can predispose to acute renal failure as well as interstitial nephritis. Now, what would you expect to see in the labs during aspirin toxicity? Well, early on you'd see respiratory alkalosis, which transitions to a mixed metabolic acidosis and respiratory alkalosis. You can learn more about those values in your renal review. What should you worry about when giving a child aspirin during a viral illness? Good, Reye's syndrome, which is marked by neurologic disease and hand wringing. Do you recall when is the only time to use aspirin for children? To treat Kawasaki disease, where the benefits greatly outweigh the risks to treating. In this case, the risk of developing a coronary aneurysm, as seen in this X-ray, outweighs the risk of developing Reye's syndrome. Aspirin is also known to cause tinnitus, or ringing in the ears, in some patients. The COX-2 inhibitors are indeed a class of drugs, but in America, the only one that's still available on the market is celecoxib. The goal here is to specifically reversibly inhibit COX-2, but to keep COX-1 levels normal. Now, why is this important? The idea is that COX-1 is an important mediator of GI ulceration, and eventually bleeding when it's inhibited, a common reason to discontinue the use of NSAIDs. So this is an attempt to selectively block COX-2 and decrease that side effect. COX-2 is also the isoform that's thought to be more responsible for inflammation and pain anyway, so it's the more important one to block regardless. What about the effects on platelet function? Well, celecoxib does not affect thromboxane production. Now, why is this? Well, because thromboxane production is dependent on COX-1. Clinically, patients with a history of gastritis or ulcers that otherwise can't take NSAIDs may benefit from COX-2 inhibitors, specifically if they have chronic conditions like osteoarthritis or rheumatoid arthritis. These are generally the only diseases for which COX-2 inhibitors are prescribed in the US. Now, what can go wrong with COX-2 inhibitors? Well, there's an increased risk of thrombosis. Also, these are sulfa drugs, so patients with sulfa allergies should not take them. Flash quiz. Which anti-inflammatory drug is contraindicated for patients with a sulfa allergy? Very good, celecoxib, the only COX-2 inhibitor available in the US. This next category of drugs is a big one. There are many NSAIDs, but you should be familiar with ibuprofen, naproxen, indomethacin, ketorolac, and diclofenac. What is the major difference between NSAIDs and aspirin? Well, NSAIDs cause reversible inhibition of COX-1 and COX-2. The uses, therefore, are very similar with antipyretic, analgesic, and anti-inflammatory uses, but not as much of antiplatelet effect. What is indomethacin classically used for in pediatric patients with a machine-like murmur? Very good, to close a PDA when it's open. Now, the downsides to taking NSAIDs, like aspirin, are not trivial. The common concern is GI distress with ulcers as well, and also similarly with renal damage due to a disturbance of renal vasculature due to changes in the native prostaglandin levels. Leflunomide is a newer drug that acts by reversibly inhibiting dihydroorotate dehydrogenase, thus preventing pyrimidine synthesis. The big takeaway for this medication is its clinical uses. Now, initially, this drug is very effective in treating rheumatoid arthritis. Here we see a radiograph depicting the classic signs of rheumatoid manifesting in the hands of this patient. Joint space narrowing, periarticular osteoporosis, or in other words, thinning of the bones around the joints, and ankylosis, or abnormal stiffening of the joint due to fusion of the joint in a non-anatomic position. Another commonly seen disorder that leflunomide can be used for is psoriatic arthritis. The classic radiograph finding for this disease is the pencil and cup deformity. Take a look at the DIP joint of the long finger here on the right hand. Notice that the distal aspect of the middle phalanx narrows and the proximal portion of the distal phalanx flattens. The distal phalanx will then begin to curve around the narrowed bone. This forms what is commonly known as the pencil and cup deformity, a very high yield association with psoriatic arthritis. Flash quiz. When is the only time that a child should receive aspirin? In Kawasaki disease, to avoid the formation of coronary aneurysms.